Good morning. Good to see you all here. Thank you so much for coming, and thank you for having me. Absolutely. My name is Johan Samanta, and as my good colleague Dr. Mahant said, I'm also a movement disorder specialist, and have had the privilege of treating blepharospasm for the last 20, well, I guess I started injecting in residency with botulinum toxin. So we would say about 25 years now of using botulinum toxins to treat blepharospasm. So it's because of the impact and quality of life and function that it has for patients, for people with blepharospasm, it's probably one of the activities as a physician that I probably draw the most pleasure out of, or enjoyment, satisfaction, if you will, and really is a sort of a pet thing of mine to talk about. So Dr. Mahant was kind enough to let me speak about something I truly love. So from there, so botulinum toxins have been around, well, honestly, millennia, at the very least. Botulism, which is a form of food poisoning, if you will, has been described as far back as the Middle Ages, but the therapeutic use of botulinum toxins really began with the Cold War, believe it or not. So the threat of, total annihilation was not nuclear only. So there were fears that the Soviet Union may try to use something like botulinum toxin or botulism to poison the water supply and whatnot. So, and of course, the military powers on our side were very keen to have their own retaliatory ability. And while that part is pretty dark, what came out of it was, well, we better figure out how this stuff works. How do we, what's it gonna, how much does it take to do whatever? And so during the 60s and 70s, a great deal of research was done, not just on, ingestion, but looking at purified components of the soup that the bacteria make, and isolating some of those proteins or toxins, because it turns out really that a number of sort of ingredients are made by the botulism bacteria. And so as they identified individual proteins, the seed of an idea began to grow that, well, if we had a pure enough supply, and if it's small enough, in small enough doses, there actually may be some therapeutic benefits. And an ophthalmologist in San Francisco, Dr. Alan Scott, was really the first to apply that. He got a grant from the Department of Defense to begin a human trial of what he had called at the time oculinum toxin, for a set of, at that point, unsatisfactorily treated ailments that he and other ophthalmologists were dealing with, and including strabismus, which is sort of lazy eye or pulling of one eye in or out, often treated in childhood, hemifacial spasm, and blepharospasm. And after many years of collecting data and studying its use in these patients, a Botox, which was the first botulinum toxin to be approved in the United States, was approved basically about a decade later. And so it was, in fact, approved first and foremost for blepharospasm. strabismus of certain types, though really I don't know that there's much use of that at this point in medicine, but for that particular purpose, and disorders of the seventh cranial nerve, which de facto is kind of hemifacial spasm. And then in the United States, there's kind of a gap, but about another decade later, the FDA approves a second botulinum toxin, Myobloc, which is from the type B serotype, and so which is essentially a different strain of botulinum toxin. And then a decade later, as it happens, the FDA approved Dysport, which is another type A, or the same serotype or strain as Botox. They approved it for cervical dystonia, same thing for Myobloc. So they were, in the US, they were not originally, they did not receive an indication or did not pursue an indication for Blepharospasm specifically. And then a year later, Xeomin, again another type A toxin, was approved for cervical dystonia and Blepharospasm. So over a course of about 40 years, we've seen some steady evolution and expansion of our options for treating Blepharospasm and the like with these toxins. And so, and to sort of follow back on those indications, so the FDA approves drugs based on, or treatments based on, what they were studied in the US or in North America, and hands out what do we call indications. So now, then there is what do we as physicians in the community do with those treatments? So we get into the area of on-label versus off-label. So if it is, we have been using aspirin to prevent heart attacks for decades. Well, that's not part of its original indication. That's called off-label use. And so the fact that only 2 of the toxins officially in the US have an indication for Blepharospasm doesn't mean that we can't or we shouldn't use the other toxins. It just is a matter of sort of on the formal side, the FDA recognizes those 2 but not the others. To make it a little more, to add another layer to it, if you look at most insurance coverage guidelines, Medicare, for instance, really treats all 4 toxins as equivalent. Not in dosing, but in usage. So they don't make a distinction between using Dysport or Myobloc or Botox or Xeomin when it comes to a particular diagnosis. And then to make things further complicated, depending on your insurance plan, what they may actually prefer is which one they're able to acquire for the least amount of money. So that occasionally you will, depending on your plan, run into a preference for one toxin over another purely based on that. The good news is, though, that all of the toxins are quite effective, and really at this point, as Dr. Mahan already said, using botulinum toxin is really the treatment of choice, and it's pretty simple. You don't need to run into the systemic side effects that you get with oral medications, so sedation, drug interactions, memory complaints, or habituation, or the risk of addiction, say with benzodiazepines. And if you compare just in terms of what data's out there, a far higher response rate. So there are a few studies that would suggest, given a series of treatments, 2 to 3, by the second or third round of treating someone, 90% or 90+% of individuals are going to have are going to see a marked improvement, 70% or better in their blepharospasm symptoms with botulinum toxin, where we are lucky to see maybe 25% or so response rates for oral medications. It doesn't mean that there isn't a role for them, but there is clearly a gap in terms of just the effectiveness and the tolerability of these. The majority of the toxins have had multiple large clinical trials that have shown and proven this effect. So the science is behind them, as well as 20 plus years of experience with them, 30 plus really. And as I'd mentioned previously, there are two different serotypes. There's type A, which includes three different, if you will, brands of botulinum toxin. There's Botox, Dysport, and Xeomin. In type B botulinum toxin, Myoblock. And as Dr. Mahant had sort of mentioned in her talk, the way the toxins work is fairly unique, but it bears is worth sort of exploring at least briefly here. So even though we inject the muscles, that's not actually where the toxin itself works. So when we inject them like an eyelid muscle, so that's where we target the muscle that is overactive, and so we inject there, but the toxin's actually taken up into the nerve ending, the motor nerve that connects to that and is telling that muscle to contract. And the important thing about that is, so voluntary muscle, everything outside of basically our gut and our heart, is what we call striatal muscle or voluntary muscle. And it needs a signal to contract. So if it's not getting a signal, its kind of baseline state is to be relaxed. So the idea behind botulinum toxin is we're trying to dial down the signal coming into that muscle. And what we're playing at is we don't want to turn it off. That's not very functional for, from everyday life either. But what we do want to do is just dial that background noise, that R2 part of the reflex back down so that it's more in line with what we would all feel is normal activity, right? And so the botulinum toxins, and there are like 7 or 8 of them, as you can see up here. What they do is they actually go into the nerve ending. The toxin itself, or the active part of this protein, which is what the toxin is, it goes in and it's like a pair of scissors. And it just clips whatever protein it has been designed to clip. And then there are 3 or 4 different proteins that various forms like to target. And it just so happens that these proteins are really important. They're part of what I would call like the docking mechanism for the little packets of signal in the end of the nerve that tell the muscle to contract. So these are called the synaptic vesicles. And when your brain and the facial nerve is trying to tell a muscle to contract, it needs to release those packets, and the more it releases, the more it tells the muscle to contract. And for the majority of the toxins that we use, so the type A's, they work on something called SNAP25, which is that green guy over there. And by clipping that, and they just go in there and just imagine almost like a lawnmower, just clipping grass, right? So they're doing their best to clip that. And now that vesicle doesn't have as many places to dock. And so there's just a backup and there can't release. And that's basically the premise behind that. And as it happens, the type B or myoblock clips a slightly different one, that orange VAMP protein, which is actually on the vesicle. But the same issue, brings up the same setting where now there aren't as many proteins on those vesicles to dock into the end of the nerve. So, and whether it blocks, whether it snips SNAP25 or VAMP, it's not clear that that makes a big difference in, how effective they are or how, or whether it's going to work. Clinically, what we see is actually a pretty similar outcome either way. So, and really, that's what we see in clinical trials. Generally speaking, you get very similar sorts of outcomes in terms of, how long does it take to kick in? 3 to 7 days. Patients start to notice effects. Typically, the peak or the full blockade of a particular dose is going to be reached at about 14 to 15 days. So that's why, for the most part, you're not going to feel or function very differently than when you walk out of the office after injections. It's not until a few days later that things start to gradually sort of settle down. And then there's sort of a plateau period. And over the next 10, 12, 13 weeks, you begin to start to see a little gradual decline in the blockade. And towards the end of that time period, it's not unusual for the patient to experience some a gradual return. And typically, the duration of the benefit is somewhere between 12 and 14 weeks. I have patients, because none of us is exactly by the book. There are folks who might notice changes maybe as early as 10 weeks, and they feel like, okay, I'm definitely starting to blink more. There are patients who I see, gosh, they come in, it's 4 months, and it's just barely starting to become noticeable again. And I think those things are due as much to individual metabolism, things like that within the cellular confines as anything else, and probably not particularly a part of, technique, or as much as I would love to say that, but then I have to own all the folks that also are only having to come in at 10 weeks. So I think the reality is we're just all a little bit different. Now, as much as I love botulinum toxins, and I think they really, truly are, at this point, still the best, most effective way to treat these symptoms. They're not perfect, and every treatment has the potential for some adverse effects. The most obvious ones are things like drooping eyelids, so ptosis, and that I'll sort of point out on the next slide, I believe, or maybe the slide after that, or one of the next slides, a little bit about anatomy. We think droopy eyelids, droopy upper lids are really a matter of location and local spread. So dry eye is certainly not uncommon, and maybe I think it's probably underreported as a side effect with Botox. Oftentimes folks are so excited that things are just better that they may have a little bit of dry eye and they don't really, by comparison, it's such a small thing that they don't really mention it, or it doesn't always register with us as like, oh, that's probably my treatment. Out here in Arizona, it's very easy to, I don't know many people who don't have at least some dry eye. And so that can also be confusing. But again, I'll show you here in a minute in a couple slides why dry eye can be, is likely at least to be related to your injections. And in more extreme cases, you can get things like double vision. So the muscles that control eye movement are, right below and a little bit deep, but not far below the eyelid muscles. And so if an injector is maybe going a little deeper than intended or is using a larger dose, there is at least some potential for some take-up or uptake in those muscles as well. The important thing with these side effects, though, is they are transient. They're temporary. Just like the benefit of Botox doesn't last forever, side effects are not going to last forever. They typically last days to a few weeks. And the other part is because Botox isn't, permanent, we can adjust what we do each time. So if we run into a droopy eyelid, well, then the next time we're going to adjust the dose or change maybe the location that we inject a little bit to try to avoid that in the future. In a vernacular, it's sort of like, getting your Botox shots is a little bit like getting a haircut. If you didn't like how it turned out last time, well, we're going to do something different next time. And I think that's, that may be a little lighthearted, but it really sums it up, is you're not stuck with the side effects that you get if you do get side effects, or you shouldn't have to be. And the other thing that comes up, I suppose, is also, treatment resistance. We have known since the 90s that, there a certain percentage of patients, and back then it seemed to be maybe 15 or 20% or 18%, something like that, that might develop treatment resistance. And that was thought to be antibody related. You were introducing a foreign protein into the body. And so just like an inoculation, you can develop blocking antibodies to these proteins, and that would render them ineffective. The science hasn't completely validated that idea. It is probably antibody mediated, but it's not clear what the antibodies are actually being made for, or that everybody who has antibodies or that has developed antibodies to the botulinum toxin is going to be resistant or lose effectiveness. The other thing, particularly in blepharospasm, that seems to raise risk for developing resistance or a loss of response is actually frequency. So how short of an interval are you going through your injections? Now, I think in general, we would look at the numbers and say that if you're being injected every 12, 13, 14 weeks, you don't need to try to stretch it out if you're having symptoms. That's not what we're saying. But what was certainly more common in the early days of treating blepharospasm was to have patients come in 2 weeks later, and if they were still blinking, well, they got a little extra. So they got a touch-up or a booster, which I think is a very ironic term to use in that setting, because I think it is a little like getting a booster, of a vaccination, right? So you're just introduced a foreign protein, and then you give somebody a little extra foreign protein a few weeks later, and now you're really, really exciting that immune system. And so folks that had a history of getting boosters or touch-up injections in the first 2 to 4 weeks seem to be far more likely to develop a loss of response or resistance to treatment than patients who were going, 10, 12, 13 weeks out. So the moral of that story is, it may be better to, if you don't have ideal outcomes with a treatment, with one of your, during your treatment cycle, and you just seem to have a dud of a treatment, it may actually be in your best interest to sort of put up with it, as frustrating as that may be, than to try to come back in and get some extra injections. There are 4 toxins, as I said. They are, while the three of them are based on type A botulinum toxin, all of them have slightly different properties from a biochemical standpoint. So, Their structure is a little bit different. The way they are stored and reconstituted is different, and therefore there are differences in the unit potency and the what we call a dose response curve. So as you increase the dose, how much more of an effect does it have? And it turns out they're definitely not, these aren't sort of nice, clean, straight lines. They're what we call sigmoid. So you start a low dose, you get an effect, and then it sort of flattens out for a bit, and then it can really sort of shoot back up as you get to even higher doses. And those patterns are a little different for each toxin. And the key is that means that at a given dose, it's not a direct, there isn't a direct conversion. So whenever I might switch from one toxin to another, I'd take the approach of, well, we sort of have to start a little bit from scratch. So we won't just jump into, oh, you've got 40 units of Xeomin, and now I'm going to give you 100 units of Dysport or something like that. I'm going to start back down at what would be a lower or a kind of more of an introductory dose and work my way up. And then you see Myoblock, which is the type B, and its units are an order of magnitude different. It doesn't mean it's less potent, it doesn't mean it's less effective. They're just graded differently in how those units and what those units mean as pertains to the effect you're going to get for a particular dose. And here's where I kind of wish I had a working pointer, but we'll do our best here. So, no, much as I wiggle this, it's not going to show up over there. So, so here's the face, and what we have here is, we all look better with skin on, right? But let me see, what might be the best way? Unfortunately, I'm just going to talk really loud, and I'm going to go over here. Here we go. Okay, this way, I don't have to yell, and you guys actually can hear me. How about that? So the levator palpebra runs basically up and down the middle of the eyelid, and in some people it's fairly narrow, and other folks it can be a pretty broad muscle, and so that can complicate matters when we're trying to inject. So if someone is having, recurrent issues with a droopy eyelid, that it may just be a matter of anatomy. And usually what I try and do is find the best happy medium between dosing and possibly adjusting my location. And I've got another slide coming up that kind of addresses where do we put these shots, right? And I think the other anatomical feature is that right about here, so in that upper part of the lid on the outer corner, that's where your lacrimal gland is. So you can imagine if we're injecting around here, boy, that lacrimal gland's not very far off. And again, they aren't neat little dots. They're kind of these spread out things, and can vary a fair amount from one person to another in terms of how low or high or deep they are in this general region. And as we have found over the years or decades, well, botulinum toxin is pretty effective at reducing things like blocking sweating. So the dermatologists have been using that for 20 plus years for excessive sweating or sweaty palms, things like that. We use it in our Parkinson's patients for drooling, for excessive saliva. We inject salivary glands. So they are innervated by similar nerves in terms of the signaling as our muscles are. They're cholinergic signaling. And so because that toxin doesn't know why we are injecting it, it's just finding it's finding those cholinergic nerve endings, and it's doing its thing. So if we're close to that gland, that's going to affect tearing to a degree and can definitely lead to dry eye. And it's also why I kind of say, boy, I really suspect there's a bit more dry eye than what we hear feedback about. And so how does, in addition to, I wrote pearls and pitfalls, but I mean, really what is, let me see in here. I'm going to ask a question or two first. So how many people in here are not a spouse or friend, but a person with Blepharospasm? Let me just see. All right. And now, how many people are getting injected with botulinum toxin? So that's just about everybody. So I probably don't need to tell you a whole lot about what happens in the room because you live it. So that was the purpose behind that. But the key here is really, the injections themselves are fairly straightforward. Hopefully all of my colleagues and I are all using the smallest needle we can, a 30 gauge or even smaller, because that matters for your comfort. I have patients who actually prefer to have this done sitting up. Most of the time I do it with them laying on their back on a table. A lot of other offices, especially I think ophthalmology offices, usually use their tilting chairs, and I think it's basically whatever is most comfortable for the injector and that the patient feels reasonably comfortable with too is the best. There's no perfect position, or there's no truly wrong position between those variants. So, but it all comes down to location and making sure that you understand what muscles are involved, what they do, and that we understand the neighborhood, basically, right? So whether that's the levator muscle or the lacrimal gland, or that frontalis muscle, that forehead muscle is fairly long. You get different effects by injecting it low versus high. And the same thing for under and around the eyelid. You can get, how you relax or how that muscle relaxes is different depending on where exactly you're putting those shots. While this also can sound a little self-serving, but I think experience really counts. And there are numerous studies that have been published over the last 50 years for all sorts of procedures that show, if it's a technique-based treatment, so surgeries, in-office procedures, and the like, the more experienced the person performing that procedure is, the better your outcomes tend to be and the fewer your side effects tend to be. Where I'm obviously a product of medical education, but as a patient, I would rather not be the person that my doctor is learning on, right? So, and I think that's really probably the biggest thing that matters when it comes to treating with botulinum toxins. As a general rule, when I see a new patient, we start low. I think I had a little block up there for Botox. We start at maybe 1 to 2 units per site in the upper lids, usually a little bit more maybe on the corners of the eyes or the corrugators if I feel like they need to be injected. The other thing is, your feedback is vital. So if you really didn't have the same response after a treatment, during one treatment cycle or another, I think it's very vital that you make some notes for yourself and make sure that we know that things didn't go as well, and as much detail as you can give us. my patients are not shy about selfies and bringing them in and showing me exactly, oh, all right, well, I see where that happened, and we're going to change that today. So we're all, as much as we believe we're really great at all this stuff, we're really, at the end of the day, you're the one going home and living with the result of our work, right? So I can't emphasize enough the value of getting good feedback. It does not have to be, be nice, but, and actually, there's nothing rude about giving us feedback. If you say, boy, I really had, there were about 3 weeks where I felt like I had to do this, after the injection, or even if it was just, boy, that was the biggest bruise you ever gave me. I want to know about that. Sometimes bruises of all things are hard to avoid because we can't always see the little blood vessels, but I, for one at least, I make pretty detailed diagrams every time I inject, so they're fairly accurate, at least in my mind, about where I put the last injection. And so if I've given you a bad bruise 2 out of the last 3 times in one spot, I'm going to make sure I've changed where I'm putting that. And I'll put a reminder to myself about that. So I really do feel that, that's as important to success as anything, is good technique or, whatever knowledge I think I've accumulated. And so it's really a teamwork thing. Here, another sort of thing that has come up over the decades is, cosmetic Botox is more and more common. It seems like everybody's getting shots these days, right? Well, that's the same toxin, right? So keep that in mind, or if you're, if you go back and you're in a support group for blepharospasm, where you're talking with other people with blepharospasm, a lot of patients forget to tell me, so I ask specifically, are you getting any other, any cosmetic Botox or something like that? Because number one, oftentimes I'm injecting the same areas, and so you're getting, you're probably not getting your money's worth. And number two, it gets back to that whole thing about antibodies and resistance. So, what I tell my patients is, if there are things that I'm not injecting and you want to get, cosmetic Botox, coordinate it the same week at least. Try to get it done within a couple days of when we inject. Or, if it's a small difference in what I'm doing, I'm certainly not, I'm not a priss. And if you would prefer, if this would keep you from doing, double duty, I will do a couple of extra spots just to make sure that we're taking care of that and all of that. And I think that's, I don't think that that's particularly scandalous. That's just me. And then last bit is, where do we actually put it? So, and that is very quickly the bit that I wanted to just touch on. So the big dots are usually where I target. So we have the upper lid, and I tend to go lower to the eyelid line, as opposed to where some injectors like to go higher. Again, I find that you can get, in my practice, I find that you can get lower, more effective effects with not necessarily as high of a dose down there, because the contraction, the belly of the muscle tends to be lower there. So you're getting more toxin exactly where you want it. And staying lower kind of gives you a little more space away from that lacrimal gland. Cosmetically, now I'm not talking about doing cosmetic Botox, but just having a nice result that people don't, that people are happier with. I often will go a little lower in the lower lid, because there's sort of a no man's land here. If you relax this area, that muscle, you get a nice big bag, because the middle of the muscle kind of sags. And none of us really cares to have those. And then I add that dot there for folks that get the scrunching. Most patients will do some of this, but everybody's different. So not everybody needs frontalis or corrugator, those eyebrow muscles injected. Some people are just very hyperactive in their blinking, and that's the most troublesome part. And so for them, it might only be 4 to 5 shots on each side. Just keep it simple. If you have more facial involvement, that's when we do the other locations. So I think that is really mostly it. So I think, as all of you know who live with this, since you're all getting injected, this works. And thank goodness we have it. So thank you.